Better this way? Okay, thank you. I would like to start by organizing the committee for the invitation to give a presentation today. I have nothing to declare. And I would like to start by sharing this quote with you from Jeremy Clarkson, which you probably all know from the program Top Gear. And I will give you a few seconds to read the quote before we continue. Because his introduction, the topic of my talk today, very well. So I will talk about the background of syphilis, the clinical presentation and nasal involvement with that, and I will briefly go through the diagnosis and treatment options with you. So syphilis is a disease which is caused by the spirochete Treponema pallidum, and it's been often named as the great imitator since its extreme heterogeneity in presentation, and it's often been mistaken for other infections or conditions. Approximately 90% is sexually transmitted, and transmission occurs through either oral, anal, or vaginal intercourse. And of course, you also have other transmission routes, maternal via from mother to fetus in utero, or via blood product transfusions. And then the bacteria can only live very shortly outside the body. So when transmission occurs, it's either directly in contact with the infectious exudates from skin lesions or mucous membranes. Well, there's been a quite long history of syphilis, but starting reporting is around the 1940s, and the incident fluctuated over the years. And then once the penicillin was introduced as a therapeutic option, you see a definite decline in the incidence. But during the mid-80s, there was an extremely increase in incidence due to the sex, drugs, and rock and roll. And especially between 86 and 90s, the cases almost doubled. So internationally, the prevalence varies enormously, but you can see that it remains more prevalent in the developing countries. Well, recently there's also been an increase in SIV rates, and that's multifactorially caused because there's an increase in high-risk sexual behaviors. There's also a decreased fear in HIV infection, decline in condom use among adults and adolescents, and in some countries there's a marked decline in public health and prevention services. Syphilis is classified as either congenital or acquired, and then it can be subdivided into early and late phases. And then the early encompasses the primary, secondary, and early latent phases, and the late comprises of late, latent, and tertiary. And that encompasses the cumitous, cardiovascular, and neurosyphilis, which I already described before, is that the manifestation is really diverse, but what we have to note is that in all stages it can manifest with head and neck findings. The clinical presentation occurs within 10 to 90% after an individual has been in contact with a person with syphilis, and the characterized lesion is known as a chancre. And this is a painless indurated ulcer, and that lasts between 3 to 6 weeks. Mainly genitals, of course, it's mainly occurs in the genital area, but extragenital sites have also been described, but it's less than 10%. And presentation in the pharynx is really rare. Well, since we still have to get lunch afterwards, I've only included some pictures of oral manifestation, because if you Google it, you'll get a quite diverse illustrations. In secondary phases, the spiral gate diverges and you will get more systemic involvement. So it happens between 4 to 10 weeks after the primary lesion. The spectrum of the manifestation is highly variable. You can have the cutaneous involvement like rashes, you can have cervical lymphadenopathy, but it can only present with fever. And then if you look at the tertiary syphilis, it's extremely rare in our countries. So it entails the gummatous syphilis, the cardiovascular syphilis in about 80 to 85% of the cases, and involvement of the central nervous system is only there in 5 to 10% of the cases. And then when you translate it to nasal involvement, tertiary nasal syphilis is extremely rare. There have only been a few cases reported, been described in literature. Once it's there, you have a superficial and deep ulceration and a gumma, which is shown on the picture on the right side. And the gummatous deposit may occur in any portion of the nose, but the septum and the nasal floor are mostly affected. What happens is that the periosteum and the perigondium becomes involved, and you will get necrosis of the bony structures. In the end, that will lead to a deformity of the bony structures and the fibroid tissues, and that will give a typical saddle nose. Well, the not so sexy saddle nose, if you have a patient presenting with that, of course you first have to think of other causes like a trauma or other inflammatory or infectious disease, and looking at differential diagnosis also from the previous speakers, it's a quite long list, and this is only a short summary of it, but you have a lot of diagnoses which you can rule out. Syphilis is not typically the diagnosis which we see here, but in developing countries you can still find it. And then if you look back into history in the mid-17th and 19th century, when a person had a saddle nose, it was typically associated with syphilis. And at that time, they called it a nose like the foot of a pot, which is shown on the picture on the right. What is really important to recognize is that there is high co-infection of syphilis with HIV. So more than 50% of men having sex with men with syphilis are also infected with HIV. And there are different methods of the transmission routes. The genital ulcer has a disrupted mucous membrane, which is then more vulnerable for the HIV virus. Also, genital ulcers may bleed easily during sex and then causing the viral transmission to happen. What also happens, thirdly, is that ulcers attract CD4 cells to the surface of the ulcer, which is then a target for the virus. And then lastly, you also have the risk behaviors, which also increases the likelihood of acquiring HIV. I will briefly go through the diagnosis. Serologic testing is considered the gold standard method, and you can divide them into specific treponemal testing or non-treponemal testing. Normally, you would start with a non-treponemal test, and once that is positive, you confirm it with a specific treponemal test, and that's to rule out false positive cases. But of course, if you have an ulcer, you can also take a biopsy for dark field microscopy or other techniques like direct immunofluorescence, but also PCR testing with swabs are possible. And then treatment entails penicillin. That's the main target for treatment. And the dose and duration of the treatment depends on the phase in which the patient is at that moment. So for the primary, secondary, and early latent phase, it's only a single intramuscular doses of 2.4 million units. And then if you continue to the next phase, you will get 3 injections once time a week with the same dosage. And for neurosyphilis, you will be admitted for intravenous treatment. And of course, in tertiary the tertiary phase, there's also involvement probably of cardiovascular, so the diagnostic workup would be more extensive with either imaging or something. What's also important to note is that you should also treat as a prophylactic treatment the sexual contacts of the patients within the 3 months. And they will get the same dosage as the primary phase. Well, in the end, if you have nasal involvement, you should also think of local treatment, and it starts with nasal irrigation and ointments. And my son is demonstrating that very clearly, how he does that with his cup of tea. But the goal of the irrigation is to remove all the discharge and crust. You will kill the spirochetes by rinsing the nose. You promote wound healing and epithelial growth, and of course prevent secondary infections, also with applying the ointments. I'm already at the end of my presentation, maybe a bit sooner than expected, but key points is that syphilis has been called the great imitator due to its great variability of presentation. Physician often may overlook because it's great heterogeneity. It often mimics other conditions, and in case of a not so sexy saddle nose, you should think of syphilis as a diagnosis. Thank you.
Okay, any questions? How many of us have seen syphilis in the last 10 years? So it's not a rare disease then? Okay.
Mainly vestibular areas, not in the nose.
I couldn't hear you very well. I'm afraid you have to step up.
Not really in the nose. It's mainly autovestibular presentations. Yeah. So tertiary neurologic presentations.
Okay, thank you. There were 5 people in this audience that they have seen syphilis, so it's not that rare. I haven't seen one. Thank you very much.
Thank you.